Well, thank you so much. Excuse me. It's really nice to be here and in this beautiful city. So, yeah, we're going to talk about switching and when, how, and what. So, actually, I think it's very simple. There are probably 3 reasons that you would want to switch. One is to simplify the regimen. One, I think, is due to side effects, which we'll get into. And the third is we're now in an era of long-acting antiretroviral therapy. We have them. And that's going to be the third reason for wanting to switch. So, at this point, like we just spoke about, INSTIs, integrase inhibitors, are first-line therapy. And we don't want to go through all these trials because this has really been talked about. But essentially, 5 trials in naive and suppressed patients of bictegravir and 3 trials in naive patients of dolutegravir. And at this point, really, these 2 agents have a high genetic barrier resistance. They're potent. And so instead, we're going to really focus on new data around these drugs. Now, if you want to simplify, not start anew like we just spoke about with Gemini 1 and 2, but if you want to simplify it to dolutegravir and 3-TC, then we have to remember the TANGO study and the SALSA study. And TANGO was really taking participants who were on 3 to 4 drug antiretroviral therapy, but specifically containing TAF, and essentially putting them on dolutegravir 3-TC. But the inclusion criteria to be on TANGO was very important. There needed to be virologic suppression for 6 months prior to switch, and no history of NRTI or INSTI mutations, and no prior switch for virologic failure, so presumably highly adherent participants. And yes, the data that was published in Clinical Infectious Disease last year showed that this was non-inferior, that dolutegravir 3-TC did fine, but it's a pretty selected group, and that's TANGO. Now you would say, well, why would I even want to simplify? I was fine with my TAF-containing regimen. So the question would be, was there some advantage to simplifying to dolutegravir and 3-TC? And what we'd care about is if there was some weight advantage or lipid, and this was the bottom line that came out of TANGO. Not a huge difference in weight, actually. Going from TAF to dolutegravir 3-TC without TAF, there was no difference. Basically, there was the same gain in weight, whether you were on dolutegravir 3-TC or kept on your TAF. So there was this caveat, but this is very kind of post hoc, that for people who are obese, they were more likely to be referred for dietary counseling or weight management in the TAF group. But that was the only signal for weight. But in general, for lipids, there was a general favoring by dolutegravir 3-TC. And in fact, total cholesterol, LDL, triglycerides, it was all better to be in the dolutegravir 3-TC arm. So that is true, and that was sustained across 3 years. So that's one advantage and why you'd want to simplify. Nothing in terms of renal or bone, actually. No inflammatory marker changes. There was inflammatory biomarkers measured. There wasn't an advantage of downgrading, but there wasn't a disadvantage either. So that was TANGO. So what about SALSA? Well, SALSA is the same design, except that the regimens didn't specifically contain TAF. It was 3 to 4 drug regimens, and then switching over to dolutegravir 3-TC. Again, had to be virologically suppressed for 3 months, no history of NRTI or INSTI mutations, and we have data out to 48 weeks. This was published in CID this year, and it was non-inferior to go over to dolutegravir and 3-TC. So then you'd say, okay, what's the advantage then? What's the advantage of simplifying? And in this case, actually, it was a little bit different than TANGO. Weight gain was actually higher in dolutegravir and 3-TC, but it was specifically driven by those who had been on TDF or efavirenz, which we're going to talk about later, I think are anorectic regimens, and they keep the weight down. Both groups really, there was not a lipid advantage in this particular study, so maybe the lipid advantage is in dropping TAF, because we saw the lipid advantage with TANGO. And then there was actually better renal and bone biomarkers with dolutegravir 3-TC, probably reflecting that there was more TDF use in SALSA than in TANGO, where the tenofovir regimen was TAF. So Overall, why are you simplifying? Possibly because of the side effects. There really wasn't a difference in virologic suppression. Okay, what's another switch regimen that's simplifying? And I think of this kind of as the perfect regimen or for the perfect patient, because this is simplifying in the SWORD 1 and 2 studies from whatever you're taking as baseline ART to dolutegravir and rilpivirine. And what do I mean by perfect? I mean, you have to have no heartburn. You have to have ability to eat food and have food insecurity. I mean, you really, have to eat it with a full meal. So there are some issues with rilpivirine oral formulation. But if you don't have any of those problems, there was actually very high rates of virologic suppression with the switch and simplification over to dolutegravir, rilpivirine. Okay, what about if you have NRTI resistance? And I think this is different than switching in the case of just trying to simplify and you have no mutations in your past. What if you have NRTI resistance? This data and the data I'm going to show you on the next slide really shows us you only have two choices as your backbone. Your backbone should be darunavir boosted, or your backbone can be dolutegravir. So why do we know that? Because of all these studies. So this is the EMERALD study, and this is really a simplification study of being on a boosted PI with FTC, TDF, and then simplifying over to dolutegravir, cobicistat, tenofovir, alafenamide, and FTC. So that single pill combination that's available. And importantly, patients were allowed to have virologic failure, and in fact, there was quite a bit of NRTI resistance, and yet there was a very high, in fact, there was no restriction to be in this study of having tenofovir or FTC resistance-associated mutations, but there were very high rates of virologic suppression, 95, 91%, respectively, at weeks 48 and 96. So what do we know about the backgrounds? Was there quite a bit of NRTI resistance? Yes, there was, actually. In fact, it was a pretty small study, phase 2, and there was 38% who had M184Vs, 4% had tenofovir RAM, so the K65R, 21% had TAMs, thymidine analog mutations, and even 4% had darunavir RAM. So it's important to say that on this baseline of quite a bit of NRTI resistance, darunavir did fine. It's an extremely potent and extremely high genetic barrier to resistance regimen. So that's what we do with NRTI resistance. And then what else do we know about having NRTI resistance? These are essentially the trials that have been published over the last 2 years that have looked at dolutegravir with NRTI resistance. They're the Dawning study, the Nadia study, the Vicend cohort, and the 2SD study. And what are these studies? Essentially, to make it simple, they were all participants who had failed efavirenz NRTI-based regimens, presumed or documented NRTI resistance, and the design of all 4 of them in the third column was randomizing to dolutegravir plus 2 NRTIs or a boosted PI plus 2 NRTIs. And sometimes that boosted PI was darunavir, and sometimes it was atazanavir or lopinavir. And essentially, the Dawning study, dolutegravir was actually superior, but again, this was compared against lopinavir, ritonavir, so harder to take. And then the Nadia study was comparing dolutegravir with darunavir, ritonavir, and then quite a bit of complication in the backbone. Like, investigators knew there was a K65R, so they were actually using AZT3TC, and it really didn't matter what you used as the backbone. Dolutegravir and darunavir, ritonavir both were able to do just fine with NRTI resistance. I will point out this caveat that I think is important, which is that 9 patients in the dolutegravir arm, when they got resistance, they failed with INSTI mutations, and none in the darunavir, ritonavir arm failed with INSTI mutations, with darunavir mutations. This makes me, it's really this study and a couple of others that makes me think darunavir has a higher genetic barrier to resistance than dolutegravir. Vicend, dolutegravir versus boosted PI, same, and then 2SD, essentially same. So dolutegravir or darunavir, ritonavir has the data behind it to be used in NRTI resistance, and not necessarily switching, but even with viremia, they will bring down the viral load. So I do think, by the way, just as an aside, I think it's important, and I'm just going to say this is what I make the fellows do in our program. I make them memorize 9 mutations. And the reason is I just think it's important to know the TAMs, and it's important to know the 3 major mutations to the NRTI class. The 6 TAMs are M41, D67, K70, L10, T215, and K219. And I make them memorize those 6 TAMs plus the M184V 3TC mutation, the K65R TDF mutation, and the L74V, a back of your specific mutation. And then I have them memorize K103N, first generation NNRTI's Y181C, which confers some resistance to ropivirine as well, but etravirine, and then E138K, the ropivirine associated mutation. And then everything else I put in my phone. So I have these 3 friends. I have doravirine, I have darunavir associated mutations in my phone. I have lenacapavir actually now, and then that way I have at my fingertips the other major classes, and I don't have to memorize the 11 darunavir associated mutations. And anyone's welcome to text me, and I will send you those phone numbers. And then when you're lonely, darunavir can be a very good friend. So, so let's go to the second reason why you'd want to switch, and this would actually be side effects. And this is really trying to put all that weight data together, because it has been, since 2018 CROI, it's been a really interesting 5 years thinking about weight. I mean, I think it's right what Milos just said, that essentially it's really the second generation INSTIs and TAF, and especially together, that seem to be associated with more weight. And the advanced study, which was shown in the previous talk, showed us that for the first time, with dolutegravir TAF having more weight than the other 2 arms. But I think if you want to put the data all together, and there was quite a bit of data from CROI 2023 about this, I think you can come up with 3 big principles. And one is that efavirenz and TDF seem to be anorectic. So it's really the change from going from efavirenz, and especially when it's with TDF, to dolutegravir, and especially when you're switching to TAF, that leads to that kind of suppression of anorexia, and that weight loss goes to weight gain. And the best thing that would show us that is this study that looks like when you're going from nevirapine to dolutegravir, you didn't actually get weight gain. It was actually going from efavirenz to dolutegravir that in the IDEA cohort that weight gain happened. And then second major principle, can you lose weight with TDF if you go from TAF to TDF? And I mean, this was a study done in South African women and published now by Dr. Bosch, but this is switching from TAF to TDF was associated with more weight loss, both with dolutegravir in South African women. So that, I think, is the second principle. And then the third is, what if you drop TAF? Now, we already said that we didn't see in Tango, the weight loss, but this was a small single-site study from Amsterdam that was shown at CROI, and dropping the TAF did actually not only improve cholesterol, which we've seen before, we saw that in Tango, but also resulted in a more lean trunk mass. So I think these are the 3 things that we can get out of CROI 2023, where we are right now. TAF is escalating weight gain, and efavirenz is suppressing it. Okay, so do INSTIs increase MI risk? Milos just went over this actually, but this was a Swiss cohort study by Dr. Surial that was shown at CROI 2023. We had a study in the RESPOND cohort that was published in Lancet HIV the year before that gave us some concern that INSTI use was associated with increased MI. Importantly, however, the participants could have been on PIs, other INSTIs before, they were treatment experienced. This Swiss cohort study shown on the right from CROI 2023, these are treatment naive participants, and at least over the first 2 years with controlling for confounders, no increased risk of MI over the first 2 years. So that's reassuring. And then finally, if you're trying to switch for weight We've already talked about why you'd maybe switch from TAF to TDF, why you'd maybe switch or drop the TAF. But can you change the INSTI and have reduction in weight? Well, the three INSTIs we're using are BIC and dolutegravir and CAB. And at least switching over to CAB, rilpivirine, doesn't seem to help. The SOLAR study, which was shown at CROI 2023, going from BIC, TAF, FTC to cabotegravir and rilpivirine did not result in weight loss. And in the FLAIR study, abacavir, 3TC, TDF, and TDF, BAC and 3TC did not lead to weight loss when you went to rilpivirine. And then let's end with interest in long-acting ART. So, you know, we have 3 registrational trials that led to the approval of long-acting cabotegravir and rilpivirine. Just talked about FLAIR because that was a talk from Milosh on treatment naive. So what about ATLAS and ATLAS-2M? These are studies where this is a switch. This is a switch from whatever you're on and you're virologically suppressed and doing just fine to cabotegravir and rilpivirine every 4 weeks, which is ATLAS, or every 8 weeks at a higher dose, which is ATLAS-2M. And essentially, ATLAS really very, suppressed, doing fine, but switched over, and really high rates of virologic suppression in ATLAS-2M, and then the same in ATLAS, and then the same thing happened with ATLAS-2M. That if you switch over to the every 8 weeks, there was also relatively high rates of virologic suppression in the 152-week data that was just published last month in CID. What about the SOLAR trial that I just mentioned in terms of the weight question? This was shown to us at CROI 2023, and this is switching over from BIC, TAF, FTC, over to long-acting cabotegravir and rilpivirine. You had to be virologically suppressed on the oral regimen. But I think the important thing about switch is, why would you want to go over to long-acting ART if you're doing just fine on your oral therapy? And there were some very nice questions asked at baseline of the participants before they switched over. Why do you want to go to long-acting ART? And 47% gave these particular survey answers, but they said, I don't want to take ART home. That tells people around me that I have HIV. Or I feel personally it's a reminder that I have HIV to take the oral therapy. Or it's hard and I forget. And all of those reasons comprised 50% of the reasons why people wanted to switch, wanted to make that switch. And so I won't mention that we are looking at switching cabotegravir and rilpivirine in patients with viremia, because there is a certain segment of the population that, even though you can take oral ART and it's great, it's sometimes hard to take oral ART every day. And about 65% virologic suppression rate is what we have at 3 years across the planet, across 31 countries, according to this Lancet HIV study on the bottom left. And so that's not good enough. That's not 95%, which is where we want to be by 2030. And there's so many different reasons. It's forgetting, it's stigma, it's substance use, it's housing insecurity, it's mental health issues, but there's so many different reasons, and they vary by country and population. So do we have any data in wanting to switch? Because I just told you about the switch studies in virologically suppressed patients. What about data in viremic patients? We don't have a lot of data. This was the OPERA study that was shown to us at ID Week, and of patients across the US who were put on long-acting cabotegravir and rilpivirine, it was around 421, and 21 happened to be viremic. So that's a very small number, but 19 of those 21, or 91%, suppressed. And then we did this at our clinic, Ward 86, that we tried to put people who were either viremic or virologically suppressed on long-acting cabotegravir and rilpivirine. And importantly, our population is all publicly insured. We have a 33% rate of methamphetamine use. We have quite a bit of depression, anxiety, and mental illness, other mental illnesses. But we were interested in the homeless population, especially because their rate of virologic suppression in the city is only 27%. So we did put, we were very aware of the inclusion criteria of the trials that we just went over, but we said, no, it's okay. You don't have to be virologically suppressed. We're going to try to use cabotegravir and rilpivirine in viremic patients. And we were allowed to do that. That was sort of a a lucky thing about our public insurance. And we did put people who are viremic on it. In fact, I'm just showing you data of the first 133 patients. This will be published on July 4th in the Annals of Internal Medicine. But essentially, of the first 133 patients, 47% were not, 43%, sorry, were viremic, and 57% were virologically suppressed. And anyone who was virologically suppressed stayed virologically suppressed. They were fine. What about the viremic people? Well, they did okay, actually. Out of the 57, 55 of them suppressed. 2 didn't suppress, but I will say that they had minor mutations before they, and we knew we were in trouble right away because they didn't have the 2-log reduction that we expected. And so we've now tightened up our criteria and said, okay, maybe no mutations, but 1 had a minor and an RTI mutation, and 1 had a integrase inhibitor mutation. And then I'll end with an intriguing case, but I will end because I'm a little past time, that this is a 57-year-old man in my clinic, really just had been on therapy since mid-90s, started with AZT monotherapy, has had HIV for so long and hit a wall. He could not take orals anymore. He said, I cannot take it. There was absolutely no possibility. 4 NRTI mutations, lots of NNRTI mutations, but didn't have any INSTI mutations. So his viral load was 1.5 million. His CD4 was 142. Absolutely couldn't take it, was not doing well. We know we have no data in this patient population. So we did it. We tried lenacapavir and cabotegravir. He had too many NNRTI mutations to even have the rilpivirine on there. So we pulled out lenacapavir and cabotegravir. We actually threw away the rilpivirine because we could only get it as cabotegravir and rilpivirine. And we started him on it, and within a week, his viral load dropped 2 logs, and then he's now undetectable. So I'll just leave that as kind of an intriguing food for thought at the end of this talk, lenacapavir, cabotegravir, and I'll stop there. Thank you.